Analysis graduate program. So I work part-time as an RBT doing in-home behavior therapy.
My name is Rachel Johnson. I am in my 3rd semester at Ball State University studying applied behavior analysis. I've been a special education teacher for 3 years, and prior to that, I worked with a company that provides in-home ABA services for individuals with autism, along with parent training and supports.
My name is Kathleen Henson. I am in my 3rd semester at Ball State University. I'm currently a program director for an ABA clinic that contracts with schools to provide behavior services to students identified by the school districts. I'm also serving as a special education teacher in those classrooms in a dual role.
My name is Ashley Campbell. I am currently in my 3rd semester at Ball State in the ABA program. I am a teacher for kindergarten students with disabilities in an underserved community, and I also recently started working in an ABA clinic part-time.
My name is Katie Rooker, and I'm in my 3rd semester of my ABA degree at Ball State. I work in a clinic in Indiana as a registered behavior technician where I provide one-on-one therapy to children with autism.
Using awareness training to decrease nervous habits during public speaking. Written by Claire Speiler and Raymond Miltenberger. Communication has transformed over centuries, and now more than ever, it is clear that quick, to-the-point language is most commonly used to communicate across all areas of life. The frequent use of texting, emails, and video chat compared to letters, phone calls, and in-person conversations are strong examples of how things have progressed over time. However, speaking eloquently and professionally is still very important to continue in higher education and in most careers. In this replication study, we explored the effectiveness of awareness training in reference to the reduction of nervous habits that occur during public speaking. Those habits consisted of filled pauses, tongue clicks, and inappropriate use of the word like. 5 graduate students delivered short speeches during all phases of this study. Booster sessions, i.e. additional training, were not needed for any participants used on the habits per minute during the intervention phase. Thus, with the use of awareness training, or AT, there was a significant and notable reduction in nervous habits compared to baseline for all participants.
The purpose of this study was to evaluate the effectiveness of awareness training for reducing the frequency of 3 nervous habits that frequently occur during public speaking. Nervous habits are behaviors that involve manipulation of movements or objects of body parts that occur frequently over a time period. The behaviors included tongue clicks, the usage of or and like. Our group consisted of 5 graduate school female participants. Each participant delivered short speeches during baseline and awareness training assessment phases. Participants had the option to choose 3 different speeches. The speeches were based on experience. Therefore, research was not needed nor conducted for participants to deliver their speeches. We chose to replicate the study because public speaking and communication are a part of our daily lives. This topic was especially significant within this group because working directly with individuals, practitioners, and family members require us to communicate effectively. This study also helped to increase our awareness and self-confidence when speaking publicly. The 3 nervous behaviors were chosen by the group because of the high frequency of those behaviors occurring in our daily communication. Filled pauses such as or and like was a part of the study due to the group's frequent usage and the impact that it has on public speaking. Filled pauses can make the speaker seem unprepared and less knowledgeable about the topic they are presenting. Tongue clicks were also a part of awareness training due to the negative attention it brings to the speaker. When the speaker continues to click his or her tongue during public speaking, the attention is taken away from the purpose of the message. Awareness training was implemented to decrease the nervous behaviors, filled pauses, and tongue clicks, and increase overall public speaking skills.
The literature review was conducted to look at the importance of public speaking, as well as any studies or research that has been done on awareness training. Public speaking is a form of communication used every day and a skill one needs to possess to lead a successful life, whether it involves speaking in small groups, in large presentations, or during a job interview. Strong public speaking skills are paramount to success. When a person uses effective public speaking skills, fluency, guidance, confidence, knowledge of subject matter, and knowing the audience, the person is more likely to be viewed as intelligent and confident. When used appropriately and effectively, public speaking can serve to share information about topics that are more important to the speaker. Using spoken communication allows the speaker to share his or her beliefs, provide insight in different topics, and potentially alter the opinions of the audience. However, despite knowing this, it is also one of the highest rated stressors for most individuals, especially for those who have no previous experience. Knowing this, many of the schools and universities teaching public speaking have included a component of self-analysis, which includes recording speakers and watching themselves critiquing their strengths and their weaknesses. As public speaking opportunities continue to increase in volume and across mediums, it is even more evident that the skills necessary to make an effective speaker must be identified and behaviors contrary to effective public speaking eradicated. In an effort to eliminate the undesired habits, applied behavior analysts have conducted studies using different interventions. One of the most effective interventions thus far is habit reversal training, or HRT. More specifically, awareness training, a component within HRT. HRT is a treatment method used to address nervous tics or habits. It has 4 essential components: awareness training, competing response practice, habit control motivation, and generalization training. For the last several years, public speaking habits have begun to be studied in the area of applied behavior analysis. Specifically, public speaking habits that distract the listener from the message the speaker is trying to convey. Filled pauses were the subject of a study conducted by Mancuso and Miltenberger in 2015. Filled pauses are times the speaker utters or clicks his or her tongue, or says like not in connection with a comparison or desired feeling. The purpose of the study was to establish if HRT was an effective intervention to use to eliminate or reduce the occurrence of filled pauses. The study followed 6 female college students in undergraduate, 2 of which were undergraduates, and graduate 4 participants. It was a non-concurrent, multiple baseline design across participants. Baseline data showed high rates of filled pauses for each participant. During awareness training, which is the training that we were looking at in this study, the participants and investigator reviewed videos from baseline and established typography of behavior. Participants were given another speech topic. During the speech, they were instructed to identify when a target behavior was exhibited. They continued this phase until either 100% free of behaviors or at least 85% identified behaviors. Results of the study indicated that HRT was a successful intervention to eliminate filled pauses during public speaking. Data showed a marked decrease in filled pauses in subsequent speeches after the intervention was implemented. Another study was conducted in 2013 in which the investigators looked at HRT and object manipulation. There were 91 participants, 30 participants in the HRT group, 30 in the object manipulation group, and 31 on a wait list. Those on the wait list did not receive an intervention. Throughout the study, 30 of the participants in the HRT group received awareness training, and in the other group, they did not receive awareness training. The results of the study indicated that while OM was successful in reducing nail biting, HRT had a higher success rate overall, including an extended success rate over OM. In 2012, another study was conducted to determine the effectiveness of HRT on chronic hair pulling. A 22-year-old woman was not taking medication for this and chose to undergo only HRT intervention. During that training, awareness training was also applied as a component. The woman, as well as the instructor, went over the topography, and she was giving different techniques to avoid engaging in that behavior. At the end of the study, which was 12 weeks long, she went from 22 occurrences of hair pulling to 0 occurrences of hair pulling. In another study conducted by Wisco and Klatt in 2013, they observed a boy with Tourette's syndrome, Asperger's syndrome, and attention deficit hyperactivity disorder. They used HRT training, which again included awareness training, to determine if this was an effective intervention for this young boy. He was 9 years old and was working with 4 tics, including eye tic, facial tic, mouth tic, and shoulder tic. There was a multiple baseline study across behaviors. In the end, after the intervention was completed, HRT was determined to be successful in reducing the tics for the boy. Another study by Freeman and Duke in 2013 looked at the stereopathy of a 3-year-old girl. In this study, which was remarkable because it was taught to the mother, who then taught it to the child in her natural setting. Like all of the other studies, HRT proved to be a successful intervention, although it was implemented by the mother in the natural setting. This indicates that HRT and awareness training independent of HRT can be implemented across multiple behaviors, is highly adaptable, applied on different settings and by different people, not just practitioners.
The participants in our study included 5 female graduate students: Ashley, Katie, Cecilia, Rachel, and Kathleen. Each participant was enrolled in the master's program for applied behavior analysis at Ball State University. And since all the members lived in different locations in the United States, it was decided to meet online every Monday evening. Our meetings consisted of video calling or messaging on the app GroupMe. The materials needed to replicate this study included a video recording device, a phone or a laptop to record data since paper and utensils were not used, a Google Doc for baseline data collection, a Google Doc for intervention phase data collection, and another Google Doc for IOA data collection sheets. We also use Google Sheet for graphing purposes. The data collection, we used frequency recording, which was separately for each type of speech habit. Occurrences of filled pauses scored upon the ending of each speech sound. Occurrences of tongue clicks are scored upon the discrete ending of each click sound. Target behavior frequency was then converted to habits per minute. Target behavior data was then compared to intervention data in order to create line graphs for each phase of the replication. See the next slide for the table that we used. So this was the table that we used, and it indicated baseline data, speech titles, the length of each speech, and the total numbers of speech habits per speech. For baseline, we were given a maximum of 10 minutes to take notes and deliver a 3 to 5 minute speech on the topic of our choice. Each member video recorded themselves presenting 5 speeches over different topics. The participant then used frequency to record how many speech habits she engaged in during each baseline speech. And for our intervention phase, we used awareness training in the form of hand raising. Mastery was 100% accuracy on awareness training across speeches, or 90% accuracy across 3 back-to-back speech presentations. Each member reached mastery and gave 3 back-to-back speech presentations. For our IOA data collection, we partnered up. So the first partners were Katie and Rachel. The second set of partners was Ashley, Kathleen, and Cecilia. We calculated our IOA data by the total number of agreements divided by the total number of agreements plus the total number of disagreements. Then we multiplied that by 100 to obtain a percentage. Each member in the group had a 100% IOA.
Data on treatment fidelity was calculated on at least 33% of sessions in the study. RAs watched video recorded sessions and scored the number of habits observed as well as the number of hand raises to acknowledge the habits. The number of hand raises scored was divided by the total number of habits, which provided a percentage of the treatment fidelity. Treatment fidelity was 100% across all participants. The effects of awareness training across the 5 participants showed a decrease in target behaviors in all post-AT assessments. Kathleen's habit behaviors in baseline averaged 2.63 habits per minute and decreased to an average of 1.14 habits per minute post-AT assessment. Ashley's habit behaviors in baseline averaged 3.74 per minute and decreased to 0.99 per minute. Cecilia's habit behaviors in baseline averaged 2.89 per minute and decreased to 0.59. Katie's habit behaviors in baseline averaged 5.68 per minute and decreased to 0.97. Rachel's habit behaviors in baseline averaged 2.9 per minute and decreased to 1.19 post-AT assessment. In baseline, all participants engaged in filled pauses with the highest frequency, with the exception of Katie, who exhibited the highest frequency in like behaviors. A proportionate decrease was observed across all 3 target behaviors.
You're muted.
Sorry. This is my graph with the baseline and the post-AT assessment. My first speech at baseline had a very high rate of behaviors, but then I dropped back down and only went up a little bit. I stayed pretty steady during the baseline. And then in my post-AT assessment, I also stayed pretty steady with my first 2. And then my last speech, I actually dropped down. So you can see how I was able to reduce those behaviors and identify when I was doing them.
My data in the baseline session showed that I also had very high habits during my baseline. I dropped tremendously during the 4th phase, and then I kind of went back up again. And for my post-AT assessment, you can see that my behaviors decreased drastically, and they kind of stayed in the same area or about the same during phases.
So my baseline, again, just like the others, started with pretty high frequencies of habits per minute. My highest target behavior was filled pauses, so saying or and then after the intervention, I decreased dramatically, only with having a range of 0.44 to 0.74 habits per minute.
As you can see, my baseline data was extremely high compared to my post-AT assessment. I realized that once I was raising my hand, I could obviously improve and catch myself making those mistakes. So once I was done with my baseline data, you can see that my post-AT assessment was pretty low. My average was 0.97 per minute. So I decreased that by a lot.
So I believe that awareness training was successful intervention for me because I noticed myself speaking slower and I thought more about what I was saying before I spoke. During the baseline phase, I found myself going off on more tangents on the related topic, whereas in the post-AT assessment phase, I stuck more with my notes and what I prepared to say. Usually, if I become nervous, I speak a little quickly and add more filled pauses than I would if I spoke slower. So even now, I'm concentrating hard on enunciating and speaking clearly. And now, even when I talk with friends casually, I'm more aware of my improper use of like and the use of or us. So overall, I think this was a great intervention for me. So these are the three main limitations that we came across while replicating this study. In the original study for baseline and intervention phases, the speeches were presented live to the principal investigator or the PI. However, each graduate student that participated in the replication study is located in different parts of the Midwest of the United States. No participants were in the same area to make this possible. Therefore, in order to collect data correctly, speeches were recorded in some way. This included the use of computers, smartphones, or tablets. Once the speeches had been recorded, they were then reviewed by the speaker to record the habits observed throughout the given speeches. This process occurred for 5 speeches in the baseline phase and 3 speeches in the intervention phase. By definition, public speaking is presenting or speaking in front of other people or an audience. So for this replication study, there was no good alternative to this that did not include incorporating other people in the study. In the guidelines created for this replication study, it was clear that no members of the outside of our group were allowed to be part of the study. Recording the speeches to then review after or at a later time was the most effective option. As stated previously, the PI was an individual that observed all speeches for each phase in the study. The PI was the contact person for the study as well that explained the parameters for each phase. For this replication study, there were no outside individuals that participated in the study. Therefore, each part of the study that involved the PI needed to be adapted. For the baseline phase, the PI recorded the number of habits for each student while they were giving the speech. Our solution for this limitation was to record the speeches and review them after and record frequency of habits ourselves. For awareness training, or AT, the PI consulted with each participant individually to discuss what AT is and how it is used. This part was probably varied the most from the original study for us. We reviewed the original study for the how-to and guidelines in order to familiarize ourselves with the concept. Finally, for the post-AT phase, the PI supported the participant as needed during the live speeches and then led booster sessions if the participant did not meet the expectation. Again, we recorded our speeches and used AT while giving our speeches with no outside help. Then following that, reviewed our speeches to record data. It was difficult to not incorporate another individual in the study when the PI played such a relevant role in the original study. Within the last phase of our study, IOA data was necessary to determine the validity of the use of AT. Most commonly, IOA is taken simultaneously with the original data collector and an outside individual who has been familiarized with the criteria of the study. However, the use of individuals outside of their participants was discouraged. So to create the most similar outcome, the speeches were reviewed by the speaker, acting as the PI, and then shared with another group member to find inter-observer agreement. This method of IOA data collection is rarely used, but was the most reasonable alternative for a replication study. All three limitations that were discussed, recording speeches for all phases, lack of PI, and IOA data collection method, either altered or limited our replication studies results and/or outcomes. These restrictions were difficult to overcome throughout the study, but it is necessary to explain how they were handled and why they existed in the first place. Fortunately, our replication study was very successful for all participants despite the limitations.
From the data obtained from the study, we can conclude that awareness training had a positive impact on decreasing filled pauses, tongue clicks, and the use of the word like in public speaking. All 5 of the participants showed a significant decrease in their habit behaviors during post-AT awareness training assessment sessions than during baseline. Comparing the results to each participant during post-AT assessment showed that their averages were in close ranges of each other's. Results show that there was no overlap with baseline and post-AT assessment. An interesting difference between our study and the original study is that all participants required booster sessions. In our study, booster sessions were not required for further reduction of behaviors due to participants' significant decrease in habits during the post-AT assessment phase. Participants reported that they were more confident delivering the speeches during post-AT assessment phase because they knew exactly what behaviors they were looking for. Future research could include the decrease in speech anxiety due to awareness training as well. Social validity in this study indicates that awareness training was an effective, easy to implement, and engaging intervention. In the original study, participants were provided with questionnaires that assessed the acceptability and coherence of the intervention and satisfaction within their outcome. For this replication study, questionnaires were not given. Instead, each participant informally stated how satisfied they were with their results in the study as a whole. Participants particularly liked the ease of implementing the intervention and being able to watch their behaviors on video as well as their peers. Participants felt more connected to their group members due to pairing of individuals during the IOA phase of the study. Being able to speak about topics that interested the participants was a motivation to complete the training with accuracy and precision. In the study that was replicated, the participants were required to complete booster training sessions due to nervous habits not decreasing by at least 80%. In our study, it was not necessary to complete a booster training session. Each participant's data during post-AT assessment agreement was more than 80%. There were several advantages to replicating the original study. Participants were given full range to choose topics to speak about as long as they did not repeat the same topic. Participants were motivated and actively engaged in their speeches. Awareness training from the study could also be generalized to recognize other nervous habits during public speaking. Awareness training can be used to shape public speaking behaviors in a variety of settings. During the post-AT assessment, participants showed awareness of habit behaviors in various forms, along with the raising of hands when a habit behavior occurred. Participants would also smile or make facial expressions, engaging in a novel response to show that they were aware of the behaviors that occurred. Participants reported that raising their hands each time a habit behavior occurred prompted them to take their time and think about what they would say next. Future research might incorporate group speech assessments to further help with nervous habit behaviors and build confidence in the speakers.
The following slides show the references we used during this replication study.